Okay. So basically what I have been instructed, the mandate is that we discuss mainly the first line and mainly on the left side of this thing. So I think I didn't try to interrupt too much about these things, slides and this thing. But I probably, in case the audience is still around, probably would love to have extempore some question from the audience rather than what has been prepared. So basically we are trying to, can we move on to the second? Welcome all the panelists. So basically, the idea is to choose right treatment. It's not right side, but the right treatment sequence in left-sided RAS wild and BRAF wild type metastatic CRC. And I believe most of the time when we discuss this thing, these are the bases which are not considering the unresectable, which are not considered resectable tumor. Can I, so that we try to discuss 2 or 3 questions important, and since we are the 4 panelists, will take their opinion. Can I have the second next slide, please? So basically, important question which Amish also alluded to and probably did show algorithm and the sequence also. So what influences the treatment choice in metastatic colorectal cancer? Which sequence is preferred and why? Basically, when I say sequence, this does include chemotherapy as well as targeted treatment. And Amish and Dr. Shyam Agarwal did cover some part of the patient with MSI high tumor. So probably we can go to this thing. So so, Ghanshyam, since I can see you, so what influences the treatment choice in metastatic colorectal cancer?
So left versus right, fitness of the patient, and at least the 5 markers like the MSI, PD, and the HER2 new BRAF and the all RAS. So this is going to be my baseline for any systemic therapy with or without targeted therapy for a metastatic colorectal.
All right, since you did you say about the HER2 new as well?
Yeah, sir. 5. So
okay.
KRAS, NRAS, HER2 new, MSI.
Amish, for the first line, since we are still there, and so what is your opinion about the first HER2 new in the first line setting?
So we do not have enough data where it has shown that in the first line compared to chemotherapy and targeted, it has shown overall survival benefit. So even if you see NCCN guidelines, they clearly say that if the patient is not fit for intensive treatment, then you can consider the combination of trastuzumab plus lapatinib in the first line. Otherwise, second line onwards, all anti-HER2 can be one of the option.
Sir, I will add to what Amish said, because if you pick up an HER2 overexpressed or a mutant, so probably your anti-EGFR choice won't be there. So that's another point.
Okay, so we do most of the time, like, can we move on to the second slide? So basically, what are the important, Ghanshyam has said that the RAS, BRAF, MSI, tumor location, of course, is very, very important. And I did not highlight the HER2 new in the first line because probably most of the time, I would say at least that probably it becomes, we are not having adequate data to use any HER2 targeted treatment in first line. And of course, Ghanshyam did allude to about the patient characteristic, this thing, comorbidity, age, first previous treatment. But the important point which Amit also highlighted and Ghanshyam reiterated that we need to have this thing RAS, BRAF, and MSI status known in front of us for any patient. And of course, tumor location is very, very important factor. And we know. So, Dr. Nidhi, what is your opinion about tumor location? So do you feel that this is more common left side, or do they do better than the right side? What is your opinion? Is Nidhi around?
So right side usually appear to do worse than the left side, and they are more commonly found to have mutations of RAS and BRAF. So and of course we prefer to use EGFR targeted therapy in left-sided tumors.
Okay, can I go to the next slide, please? So of course, now we have the ample evidence which suggests that the whatsoever the reason may be, the bottom line remains that the left-sided tumor do better than the right-side tumor. Of course, Nidhi did say that they have a lot of poor prognostic factors, probably in the right-side tumor, and we have more EGFR, this thing, this MS, height TMB on the left side. They are these. So of course, the bottom line is that the left-sided do better than. We have number of evidence for that. Can I go to the next slide, please? Next one or two. Of course, the various guidelines, whether this is NCCN, ESMO, or ESMO Asia, everything suggests that they probably the right side tumor do worse than this thing. So, Dr. Venkat, the important question, does treatment sequence matters? If yes, what should be your choice for that? We are discussing the left side tumor, BRAF wild type, KRAS wild type. What should be the first line choice, second line, and probably so on?
Good evening, sir. The main determinants of sequencing are the molecular mutations which we do and the results of the test. So if it is KRAS wild type, definitely targeting EGFR has shown better outcomes in left-sided metastatic tumors. So chemotherapy plus EGFR target therapy antibody is will be my first choice, sir. So after that, depending upon response and duration of response, I will choose my second line therapy, sir.
So a follow-up question to these things. When you say EGFR plus chemotherapy, do you have any particular chemotherapy protocol in mind, or what are the factors based on which you decide the chemotherapy should be used?
In a patient who hasn't received any previous therapies in adjuvant or other settings, definitely oxaliplatin and 5FU-based chemotherapy will be my choice to combine with antibodies.
Any specific reason for that? Do we have more evidence with the oxaliplatin-based chemotherapy?
Or no, sir, not at all. But there is no particular evidence that FOLFIRI or FOLFOX will do better in the first line, sir. So there is no
patient is treatment naive, unresectable metastatic colorectal cancer with the RAS wild type, BRAF wild type. So Ghanshyam, any particular combination?
So evidence is more because if you look at the trials, so the oxaliplatin trials were more than the irinotecan in the first line.
In fact, the first trial was the crystal trial using the FOLFIRI.
But subsequent to see all most of them were 60% have received actually, if you put together all first line, so they are oxaliplatin based. And most of them were US based trials.
Amish, you want to comment on that?
Sir, Americans use FOLFIRI a lot, but as Ghanshyam said, many of the academic institutes use FOLFOX. The only problem with FOLFOX is neuropathy. And second thing, nowadays, a lot of that oxaliplatin can modulate the microenvironment for future treatments. But sir, I use FOLFOX more commonly because it is easily tolerated and there is no hair loss with FOLFOX. So as a result, people take it very nicely in the first line, sir.
All right. So I have little difference of the opinion, and then probably what I say that of course I agree that it doesn't cause alopecia or this thing. But personally, I think that FOLFIRI is better tolerated than FOLFOX. The simple reason being that after a couple of cycles, probably they end up having either the neuropathy, and then probably either you reduce or compromise the dose or this thing. But I agree and concede that no data which suggests, in fact, that trial has clearly showed that whether you use FOLFOX, FOLFIRI, or FOLFIRI, FOLFOX doesn't make much of a difference. So I agree to that. Next slide, please. Of course, we don't need to discuss this question. If there is a left side tumor, RAS and BRAF wild type, probably obviously everybody will be using the EGFR inhibitor. Anybody wants to take a question whether it should be the cetuximab, or is there any difference between the cetuximab or panitumumab?
So most of the trials are with cetuximab, so that's why so probably we are mostly accustomed with cetuximab.
Toxicity, personal experience, toxicity.
So for personal experience, the toxicity probably for me, so panitumumab was more toxic than cetuximab.
Is it?
Yes, sir. Though
does it have the similar experience? So it is chimeric versus this immunized, so probably it should be the
other way, right?
Yeah, Nidhi, do you want to comment on that toxicity, EGFR inhibitors?
So this actually, as you're saying, it should be the opposite, but my experience also has been like Dr. Ghanshyam Biswas, and I also found panitumumab to be slightly more toxic. than cetuximab. But also because of the cost issues, I prefer to use cetuximab rather than panitumumab, sir.
Okay, cost is almost the same. There's not much difference between the cost, I believe. Anyway, I hope the first slide which showed this mark probably is not influencing our decision. But anyway, the other point I probably would like to highlight is that the most protocol probably using this thing, cetuximab, standard or approved indication is weekly, though we do use every 2 weeks, whereas the panitumumab is every 2 weeks anyway. Next, please. So this is the data which suggested that there are two meta-analysis. In fact, there is a third one also which says that if we use probably in the given situation, everybody will be using EGFR inhibitor first rather than the VEGF inhibitor. So we don't need to discuss that. Next. This again is another pooled analysis suggesting the same, that if you use cetuximab first or EGFR inhibitor first, you get the survival advantage. Next one. I can skip all these things, and the last questions to all the panelists. If you have a basically treatment naive, like Amish probably did discuss about this, RAS wild type, BRAF wild type, and also having the high TMB, Dr. Sharma Agrawal says high TMB, or if you want to believe in the MSI, high MSI. So what will be your choice of treatment? RAS wild type, BRAF wild type, high TMB, and MSI high. First line.
Sir, MSI high.
So MSI high, RAS wild type, BRAF wild type. So you have more than one choice.
Yes.
And the TMB also high.
So definitely immunotherapy, sir.
Everybody?
Immunotherapy, sir.
Which is in?
I still go for chemo plus targeted therapy, and I will save the immunotherapy for the later lines, sir, because I think sequencing do matter. That is my personal opinion, sir. I do not have any pressing evidence for that.
Dr. Shyam, since you are still there, you are sending a comment, I think. So you will go for the immuno checkpoint, or?
I raised that question. So you put it on the left side where you will have the best evidence for EGFR drug and chemotherapy. So I think since the approval is there for metastatic disease in the first line for MSI high, so I think it's all right to use the immune checkpoint.
Perfect. So I agree that both are valid options, this thing. So Amish, you were covering this part and this thing. So do we have evidence suggest that if you use checkpoint inhibitor first line and then subsequently if you want to use the EGFR, do you have any problem or any less effectiveness of the EGFR inhibitors or more toxicity or this thing?
Sir, Keynote 177 was a randomized study between immune checkpoint inhibitors and chemotherapy. And the median duration has not reached in the immune checkpoint inhibitor as regards overall survival. And you see the PFS gap in the PFS1 and PFS2. So PFS2 clearly means that after immune checkpoint inhibitors, either anti-EGFR or BEV are used. I have no doubt in my mind that if BRAF is wild type, RAS is wild type, MSI high and TMB high, I would definitely use immune checkpoint inhibitors, unless and until there is a trick question put by you, sir.
No, I won't put it.
What will you do, sir?
So
Since you allowed us to ask you question.
Yeah, obviously. So I probably will, in case the funds are available and probably everything is available, then we'll go for this thing checkpoint inhibitor.
So what about, sir, MSI high? Every situation is same, but the TMB is low.
So Dr. Shyam Agrawal did show a slide, I believe.
Yeah. So there is a difference between a high TMB and a low TMB. But if it is a given situation, then chemotherapy
is based on the MSI high.
Yeah, Ghanshyam, I think TMB doesn't really, to my mind, would make a difference. If the MSI is high, So I think the immune checkpoint inhibitor will score over chemotherapy and your targeted drug, especially if the RAS, RAS obviously is wild type,
Right.
and especially if the BRAF is also wild type. So I think the data is quite strong and compelling. I mean, you have a response rate of about 70%.
Durable, correct. And durability also.
Correct. Yeah.
All right. Probably, I think in the interest of time, probably we stop this panel discussion. I thank you, everyone. And also a special thanks to Dr. Shyam Agarwal and Dr. Amish Vora for joining the panel. And thanks to Dr. Rajat Bajaj. Thank you, everyone.
Thank you.